Treating calcium in the peripheral vasculature is quite challenging for two reasons. First of all, because of the lesion, and secondly, because of the patient. Regarding the lesions, it's very difficult to cross. We have quite good data showing that calcium is an independent risk factor for crossing failure, but also it's very difficult to open the vessel and keep it open on the long term, which means that traditional modalities quite often fail. And we have a lot of reocclusions and quite often target lesion revascularizations. On the same time, we should not forget who are the patients that we treat, because mainly patients that have severe calcification are patients with chronic kidney disease or diabetics, and both of them are very fragile cohorts, and these subjects are prone to both systemic and local complications. Because of the lesions, the risk for crossing failure is quite high, dissections, distal embolization, etc. But at the same time, these patients are high risk for systematic complications, namely acute kidney injury, acute coronary syndrome, or major cardiovascular and cerebrovascular events. So in this context, the treatment of calcified disease, and I would say the treatment of calcified patients, it's very difficult, because it's difficult to treat the lesion, but at the same time we need solutions that will not increase the risk for complications in these patients. When we talk about femoropopliteal disease, first of all, we have to clarify that we have two different vessels: the SFA, which is the longest vessel on the body, and the popliteal artery. And these two vessels lie in a completely different vascular bed. The unique environment of both the SFA, especially the distal part of it, the Hunter channel and distally, as well as the popliteal artery, make the endovascular treatment quite often difficult. The reason is that, of course, we have an increased mechanical force from the surrounding muscles, which can lead to a treatment failure, especially when we place scaffolds, if we don't prepare the vessels accordingly prior to scaffold deployment. Many physicians think that also popliteal artery is a no-standing zone. I'm not sure that we should call popliteal artery no standing zone, but for sure it's a segment that we should avoid stent when it's possible. But if we treat this segment, then we'll need for sure dedicated devices. This is a very important question. I think that what we know from the treatment of calcium is that modalities, the usual modalities that we use, are either associated with high risk for complications, and at the same time they have quite a lot of treatment failures. IVL enables the safe treatment of calcified disease because what we saw from registry data and from our own analysis that the risk of complication is quite low. And simultaneously, IVL provides a very effective treatment tool which fractures the intimal but also the medial calcification of the vessel wall and change really the compliance of the vessel. Regarding my preferences, I think that IVL showed good and promising results in various vascular beds, from the iliacs going down to the common femoral, deep femoral SFA pop, and of course BTK disease. And I think that the initial data that we have from many studies are promising and show quite consistent result in all vascular beds. So when we want to evaluate a novel endovascular device, of course, the best way to evaluate its performance is in prospective randomized controlled trials. And I think that the upcoming trials will provide us sufficient data about the efficacy of and the safety, of course, of IVL technology in heavily calcified disease. On the other hand, we all know that in a randomized prospective trial, you cannot include all kinds of patients, patients with end-stage renal disease, heavily tissue loss, etc. So What we felt is that we should evaluate the performance of the combination therapy of IVL and DCB in a pragmatic cohort of patients with CLTI, with patients with end-stage renal disease, etc. And I think that this is the majority of patients with calcified disease. And I think that, in my opinion at least, this study will provide us an overview about the efficacy of the technology in a very pragmatic cohort. In our analysis, we retrospectively evaluated patients treated with intravascular lithotripsy and drug-coated balloon angioplasty for severely calcified femoral disease, treated in San Francisco Hospital in Münster in a frame time for 4 years. We include patients, we include consecutive patients, and of course patients both with claudication and chronic limb-threatening ischemia, and the majority presented with rest pain or tissue loss. More than 50% of the patients had CLTI. Additionally, we enrolled also patients, or we treated patients with IVL with chronic kidney disease. And these are two important characteristics of our cohort. First of all, a high number of patients were CLTI patients, and secondly, patients with chronic renal impairment. In this study, we found that treating heavily calcified disease, SFA and POP disease with IVL can be very safe and, of course, effective. We had a very low number of local complications and distal embolizations, and on the long run we observed a very promising primary patency of 81%, which is of course more than satisfying given the challenging cohort of patients. So in overall, I think that with a leave less or nothing behind approach, we were able to treat many patients with challenging lesions, with low risk of complications, and with a quite low need for secondary interventions. A very important finding of our analysis, of course, was that eccentric disease, the presence of CTOs or PAX class 4 did not increase the risk for loss of patency and TLR. So in overall, when we see the acute and the long-term results of this analysis, I think that this study shows that in a real world cohort of consecutive patients with CLTI, high rates of chronic kidney disease and severely calcified disease, we have very good, an excellent safety profile and a very promising 12 months performance. Of course, we'll have to wait for the long-term results, but the 12-month results were very promising. Another major advantage of the IVL is that the results of the technology in various vascular beds were very promising, and we see good results in the iliacs, in the common femoral SFA POP, and to below the knee arteries. And this is something that is quite new for calcium dedicated devices,